Thank you, Martin, very much for such an introduction. Just a second. Yeah. So, good morning, ladies and gentlemen. So my talk will be about the perspective on STIs in Eastern Europe. I work in the group of prevention and implementation of International Agency for Research in Cancer, which is geographically located in Lyon, France, and have nothing to disclose. I will talk about generalities regarding the region called Eastern Europe, challenges and opportunities we have before going into the area of trends on STIs in Eastern Europe, and then summarize with lessons learned from taking messages. And well, we saw these slides already, so I'm not going to discuss it much. That WHO estimated 357 million curable STI cases worldwide in 2012, with many of them are applicable to chlamydia. And regarding WHO Euro, it's not as emerging area as, for example, areas in Africa and Latin America and Pacific region. And talking about Eastern Europe, I'm just curious how many people are in the audience from Eastern Europe. Can you please raise their hands? So it makes my life a bit easier. So because if I ask people in the audience what they mean by Eastern Europe, I'm sure we'll receive a bunch of different answers. And it's absolutely normal, because even within the UN, within the entire UN system, there is no clear explanation what it is. The term comes actually from the time of the Cold War. And personally, I like the classification by the WHO, which divides the Eurozone into 3 areas, and one, which is red, of course, it's the Eastern Europe. And there is something very common between all these countries, united by the Eastern Europe. It's the heritage of the Soviet Semashko healthcare system, which explain lots of obstacles there regarding STI and infections and perspectives, and how the countries were dealing with this. And Semashko system was introduced in 1918. It was present in the time of the Soviet Union and the Eastern Bloc, but also in Mongolia and the rural areas of China. And the main thing of this, it's a universal access free of charge to everybody as close to as possible geographically. So it has very strong geographic emphasis, but it has to be under direct control of the central government. The entry point is outpatient clinics or polyclinics, or in case of STIs, dermatovenerological dispensaries. As it's geographically extensive, it obviously requires extensive workforce, which results in high cost, overall cost, but as a compensation, low salaries. So it's very centralized. It's funded by the states. Facilities are mostly state-owned, budgeted, and hospital physicians are salaried. It's a bit like UK beverage healthcare system, but which gives more space for the private services, and the entry point is different as family doctors. So it also says about this heritage, talks a lot about challenges and opportunities. First of all, it's a huge bureaucracy. As you understand, the vertical system requires reports, and produce papers. And so it's very difficult to make any challenges. And there is a kind of traditions which get difficult to change. In some countries in Eastern Europe, the culture is very punishable. I don't want to mention which ones, but 0 errors are admitted there. There is no real culture of quality data, so actually there is no real monitoring evaluation active one in place. There are bad traditions on detection and treatment of STIs and STI-related disorders. For example, using Romanovsky Giemsa instead of Papa Nicolau for cervical staining, then using strange treatment modalities, so using azithromycin in treatment of chlamydia, for example, 1 gram every 3 weeks, and so on. There is a stigma in place which protects, it makes data on transmission in men unreliable. And also there is an observed decreasing of quality. Well, this is not related to exactly STIs. It's exactly to it's related to cervical cancer mortality in EU versus CIS countries. So the green one for CIS and the red line is for the EU. And cervical cancer is HPV-caused malignancy. So you see that until a certain time, the lines were kind of in parallel going down, but then they went different directions. So it's also, we observe the decrease in inequality and equity in most countries, in some countries until real extreme extent. For example, in the Kyrgyz Republic, everything which is not urgent considered to be paid out of the pocket, including not only cancer but also STIs. So there is increase in private clinics. Many of them do not provide any data, and they're just out of the focus and do whatever they want, do not follow protocols, even national guidelines. Corruption is in place. Nothing is new. Decreasing in attending licensed public services because the services was going down. And as a result, it's also increase of self-medication and actually self-detection of infections. Or increase in services provided by non-specialists. There is limited knowledge on international literature and guidelines, mostly because of the language barrier, but also there is an interesting thing that, and actually in most of the countries, there is a tradition of denouncing, I would say even reporting of any activities, including scientific activities, on the top, because it can be considered that this data may damage the image of the country. So any scientific publications may require a high level of approval, actually political approval. There is also increasing interest for research, mostly because of low capacity. There is not many specialists in epidemiology, and public health specialists have different education than in the Western countries. And there are limited resources and sometimes limited political will to do this. And as an example, I want to show the data on systematic literature review on genital chlamydia prevalence done in Russia last year. We did. And it's a big country, a sparse country with a very diverse population. And we found only 10 articles to be included in this review, which provided data from only four regions. There are also opportunities in place. There is a strong culture of registering data, so they're okay to register anything, which can be the first step for the monitoring evaluation. It comes back from the history of dispensarization, when everybody was obliged to be tested, provide blood test, urine test, STI testing for the period of 3 years. And in case if you're a doctor or medical or nurse, you had to do it every single year. All curable STIs are reportable in CIS country, which is a good thing. As far as I remember, in the Russian Federation, it became reportable in 1993. Health staff and public is okay for registering data, and politicians' values, but it raises many questions also. Public health system is under one authority, so this is a good example of Belarus health system. It's very simple because nothing has been changed so far from the Soviet times regarding this. The UZBEK health system is more complicated, but it shows the same pattern. And even the health system in the Russian Federation, which has more pluralistic and have much more space for the private providers of healthcare, it's also follow the same pattern. Well, it doesn't exclude inequity, but what it brings clear partners for international assistance and cooperation if requested or needed. And then also will help to build up national capacity quite rapidly. Human resources can relatively easily be allocated because of the numerous and badly paid health staff. And there is almost universal provision of STI through a big chain of dermatovenerological services. And there is, as I said, increasing interest for research, and the staff is in general is trained. So coming to the trends. So this is actually a trend for cervical cancer. And you can see that it's increasing. The incidence is increasing in all these East European countries, or Baltic countries, Belarus, Russia, and even Bulgaria. And it's starting actually from 1990s. And we expect that it's not only because of the changing in the healthcare system, but also changing in sexual behavior, which is more visible in case of trends for syphilis. So this red line, vertical red line, is the dissolving of the Soviet Union, and which actually result in abandoning lots of social welfare and abrupt introduction of market system, liberal market system. So you can see that actually the incidence of syphilis rocketed in all CIS countries until 1996, 1997. Then it was slowed down, downing, and up to current days, the bottom pictures show data for Russia and Ukraine. The similar trends were observed for gonorrhea, and the similar trends were observed for other infections. This is a slide I received just 2 days, thanks to the colleagues from Belarus. This is data from gonorrhea, trichomoniasis, syphilis, and chlamydiosis. So you can see the clear trend. And this is how it looks for the moment. So bacterial infections, like for example chlamydia, they have a high increase, and then incidence, and then there is a slow downing, but it has not come to the figures of 1990s. But the interesting thing is about viral infections, for example, HPV, which is steadily, constantly going up. And that's why it brings this area regarding cervical cancer incidence close to the developing countries in Latin America, and I would even say that closer to the African continent. And this is for cervical cancer, and this is quite a similar looking picture for HIV. So you can see that these areas are quite affected already. So we observed the increase in number of new detected cases for HIV in all post-Soviet, in most post-Soviet countries, as well as a decrease in number of AIDS-related deaths. So taking home messages will include some aspects on diagnostic care and prevention. Social economical changes resulted in increased incidence of STIs. And real numbers were unclear. So this is the lessons we learned from the past. And this is because of insufficient of, if any, reporting of these cases. Many providers of services came to this stage, but they were very poor controlled by the government. There was free access to antibiotics, which was fooled with the pharma, and altogether resulted in increase in common self-treatment. The STI testing was insufficient, mostly because originally when nucleic acid amplification tests appeared on the market, they were extremely expensive, and the classical test became of poor quality. So the altogether rocketed incidence of mostly bacterial STIs. So the next slide I wanted to call lessons to be learned, but it sounded less optimistic, so I call it call for actions and research opportunities. So what we have nowadays and in the coming future. So we have more pluralistic health systems in place, which are still coming through the transition phase. And it goes in line with lacking of funding, very often, mismanagement, lack of political will, and corruption. STI incidence rate, we see the trend, it's in decreasing bacterial but increasing viral incidences. And in particular, it comes to the HIV expanding epidemic. The very well-known case of it's the Russian Federation, which is, according to the UNAIDS, is now behind South Africa and Nigeria in incidence rates, and PEPFAR even put it on the first place. So that this reporting system is still suboptimal, and in several countries is still out of not really proper done. Real numbers remain unclear. There is no data on high-risk populations, and mostly because of stigma. So we just heard a comment from a transgender activist, but forget about it. In these countries, there is no data collected about that, and very limited data on MSM. So, and even if it's collected, for example, this is data on HIV-positive MSM in Russia, and for the first time we see that the proportion of heterosexual transmission of HIV is about 50%, and MSM are only responsible for 2.3%, which is not showing the real picture. And if you see the red line, vertical red line, this is when this famous so-called anti-gay, but in fact it's laws banning the promotion of non-traditional relationship to adolescents was implemented in place. So there is a trend for going down, because people just simply do not report. And then what we have a reality that's improved diagnostic of STIs in most countries, mostly because of originally, well, when all this DNA tests were very expensive, they just simply developed their own, and they have quite good quality. This is an internationally available publication about comparing the data on detection of chlamydia. But I also know from personal communication stories about at least 2 HPV diagnostic tests, which successfully went through WHO HPV LabNet proficiency study. So we still have, there is still easy access to antibiotics. You can simply go around the corner, buy azithromycin if you need to be treated. There is suboptimal treatment for HIV. There is limited, if any, except pharma-driven international collaboration or research. And in summary, what I see is a perspective for challenges and opportunities for programs on STIs in Eastern Europe. So we have to think about changing paradigms and the fact how the problem has to be addressed and how the authorities have to react. And we have to think about ensuring fail-safe solutions, in particular access to equal access to the STI diagnostics and treatment. And also reducing the stigma. And we have to promote national champions through training and research activities. So thank you so much.